A very good afternoon to one and all present here. Good morning, European partners, and good afternoon to the Indian partners. It is my pleasure to welcome all of you to the international workshop on curb antimicrobial resistance, antimicrobial stewardship, and infection control practices, organized as part of the Preventive Project, Risk Management and Prevention of Antibiotic Resistance, which is co-funded by the Erasmus Plus program of the European Union. We have 5 speakers on board for today's workshop. Before introducing the speakers, let me introduce myself. I am Dr. Donna, and I'm working as the Associate Researcher for the Project Preventive at Amrita Institute of Medical Sciences, Cochin, Kerala, and I will be the moderator for the session. Before we start with the workshop, let's understand the outcomes, what we are aiming at. The participants will be able to understand the basics of antimicrobial resistance, its epidemiology, impact, mechanisms, causes, and spread. Every problem has a solution, right? So we will also propose some solutions, and we will also talk about the initiatives that are in place right now to curb the crisis. And we will specifically focus on antimicrobial stewardship and infection control practices. A little bit more about the workshop details. The workshop is conducted over the Zoom platform, and it is streamed live on YouTube. All the participants, please feel free to drop your questions at any time in the YouTube chat box with the hashtag query. Those questions will be addressed either during the workshop or at the end of the workshop as the time permits. The workshop is being recorded, and the recorded version will be available on the official website of the Preventive Project, www.preventive.in, and also on the social media handles of the Preventive Project. Finally, e-certificates will be provided to the participants. So there will be a Google form that you have to fill. The link to the Google form will be shared in the YouTube chat box by the end of the workshop. Kindly fill the Google form to get your e-certificates. Keep an eye for the same. So let's just quickly run through the agenda. I will be setting the base for the workshop. Following that, Dr. Kiranjit Kaur will be talking in detail about the mechanisms, causes, and spread of antimicrobial resistance. Then we have Dr. Prakash from Manipal Academy, and he will be talking about the various initiatives that are in place to curb the crisis. Following a small break, we have Dr. Sangeeta with us, who will talk in depth about the role of antimicrobial stewardship, what's the need of antimicrobial stewardship, and how it can be implemented in a resource-limited setup. Then we have Dr. Carlos on board, who will be talking about the infection control practices. And finally, we have Mr. Jyothi Bhushan from the VHAT NGO, who will discuss about the role of NGOs in preventing and controlling the AMR in the general community. So before we begin with the actual expert speakers, let's just understand what is antimicrobial resistance. Antimicrobial resistance is a phenomenon in which the microorganisms, let it be bacteria, fungi, or virus, they change when they are exposed to the antimicrobial drugs. We should note the point that this is a natural phenomenon, but unfortunately, it is accelerated by the injudicious use of antimicrobial medicines. Therefore, the World Health Organization has identified antimicrobial resistance as one of the top 10 global public health threats. So antimicrobial resistance is a broad umbrella under which you have various subgroups like antibiotic resistance, antiviral, antifungal, antiparasitic. Most of the discussions in today's workshop will be somewhat where the examples will be from the antibiotic resistance part. So antibiotic resistance or antimicrobial resistance is not a new phenomenon. Actually, this was identified by right at the time when Alexander Fleming discovered the penicillin. During his Nobel Prize speech, he actually sounded an alarm that the time may come when penicillin can be bought by anyone in the shops. then there is a danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug and make them resistant. Though he alarmed this situation, we humans took a lot of time to understand what's happening. So as we see in this graph, there's a constant war between antibiotic and bacteria. So this graph basically shows when an antibiotic got developed and when the resistance was reported for the first time. So if we take the example of sulfonamide, we can see that somewhere around 1929, we developed the sulfonamide, and the resistance was reported first somewhere around post 1940-41. Another example that I can show you is another interesting example is of levofloxacin. The development of the antibiotic and the first report of resistance had a very small time interval, maybe less than 1 year. So that's how fast it's happening. So the basic point that we should always keep in mind is the injudicious use of antimicrobials are driving the antimicrobial resistance. As we see in this graph, we have the European countries over here. So this graph shows how the countries with strong antibiotic policies have very less antimicrobial resistance. If you see towards the lower end of the graph, towards the left side, you can see Netherlands, Denmark, Norway. Those countries have a very strong antibiotic policies. As a result, the injudicious use is less, and thereby the antibiotic resistance is also less. But the situation is different in other countries, especially like France and Spain. So why ABR or AMR is a concern? We should understand that globally right now, 7 lakh people are dying every year due to the resistant infections. But I must say this is definitely an underestimate because of the poor surveillance. If you look into USA, around 35,000 deaths are reporting from across the population in the US due to resistant infection. If we consider the Indian scenario, 60,000 deaths of newborns are reported every year due to AMR. It's not across the population, it's just the newborns in India. So the actual death due to the resistant infections will be manifold in case of India. We should also understand that antimicrobial resistance is not limited to a particular country or a region. It spreads across the world. And these are the 2 examples. The blue lines, those show the spread of methicillin-resistant Staph aureus. So in this map, we can see that in 1961, the first report came out of MRSA identified in UK. In the same year, in the 1960s, it got spread across the Europe, and by 1970, we could see the presence of MRSA across the world. The same happened with Klebsiella, wherein the carbapenem resistant strain was first identified across the USA in 2003. By 2005, it spread to Israel, and by 2008, it was present worldwide. So it's moving. Just like how microbes are moving, the resistant infections are also spreading across the world. So until now, we were looking onto a global perspective. Right now, we will just we'll look into the individual perspective at the level of hospital, at the level of patient. So why we are concerned of AMR at the level of patient? Because they are mostly causing treatment failures. Second thing, the resistant infections take long time to cure. So in turn, it leads to longer hospital stays. There are chances of higher mortality and morbidity rates due to resistant infections. And for treating resistant infections, we need more intensive treatments, right? And some such treatments will have more adverse reactions. And 5th point, identifying a correct therapy to treat these infections will also take a very long time. And finally, the treatment cost will be higher for treating resistant infections. So that's a concern. So AMR is a concern not only in a healthcare perspective, it's also a concern in the economic perspective. If you see the first image, you can understand that we require $700 additionally to treat a resistant infection. If we take the case of a rural casual labor in India, he has to work more than 1 year to make this $700. So in a way, these infections are pushing people back into the poverty, and poverty is again making a good ground for the rise of the infectious disease, including the resistant ones. So that's a vicious circle, and that's happening everywhere, especially in India. So what will be the situation in the future? What if we don't act right now? If we don't act right now, the future is grim. We are going to see about 10 million deaths due to AMR every year by 2050. And most of these deaths are going to happen in the continent of Asia. And if we look at the economic aspect, the world GDP loss is amounting to $100 trillion by 2050 due to resistant infections. So even though the microbes are tiny organisms, they are mighty enough to break this world. So as rightly quoted by the CDC, we need to stop referring to a post-antibiotic era. It's happening right now. And we are living in a time where the miracle drugs called antimicrobials are failing to treat the infections, and they are ripping apart the families. So with this as base, let me stop screen sharing. So with this as base, I would like to invite Dr. Kiranjit Kaur from the Chitkara University, Punjab, to enlighten us more about the mechanisms, causes, and spread of antibiotic resistance. Dr. Kiranjit Kaur is a microbiologist by profession, and she is affiliated with the Chitkara University from the year 2016. From January 2020, she is appointed as the coordinator of the Preventive Project. Her area of expertise is very wide, and it includes antibiotic resistance, disinfectants, contraceptives, lung cancer, and premature hair graying. She has participated in many national and international workshops, and she has many peer-reviewed publications to her credit. And she is a life member of Association of Microbiologists in India. Over to you, ma'am.
Thank you so much, Dr. Donna, and for a very nice introduction as well. So a very good afternoon and very good morning to respective audience. First of all, I would like to thank Dr. Donna for inviting me as a speaker. So I have been given this opportunity to talk about emergence and spread of AMR. So Dr. Donna has already set a very nice base for us. So I think it will be easy for me to take it forward. So just one thing I would like to mention in the beginning, that keeping target audience in mind, which was being told to me as students, I have made this presentation in a very simple language. So please feel free, even then, if you don't understand anything, please just use YouTube chat box as already mentioned by Dr. Donna. All right, so let's get started. Just to briefly let you know, after through my session or after listening to me, I hope you guys will be able to understand what are the factors that lead to the emergence of antimicrobial resistance. You will know how AMR spreads into the environment and other sectors, and last but not the least, you are also going to have a little glimpse about the concept of One Health in view of AMR. Okay, so before I actually begin, let me just remind again the facts which has already been shared by Dr. Donna, because these are very, very useful for you to understand the topic that I'm going to discuss. So it involves the facts in the sense we must remember that microorganisms are present everywhere. So please keep this thing in mind, that microbes are present everywhere. Plus, as our moderator has already told, microorganisms, they are not sitting idle. They are smart enough. As you can see in this picture, I hope you can see my cursor as well. They are, focusing, they are more focused, and now they have started the revolution. Maybe not today, it's long time back, but we are getting awake right now. So they have already started the revolution that, do or die situation. So either they would prefer dying or they would just want to fight back. And that is the situation where our antibiotic or antimicrobial agents, they stop becoming effective. Another important thing that you should keep in mind, these are just the facts which I'm talking about, that you should keep in mind is antibiotics or antimicrobials are not only confined to the use of humans. They are also being used in animals and they are also being used in plants. And I am sure it will be fascinating for all of you to know that if 10 antibiotics are there in the market, out of 10, 7 or around 8 antibiotics, that is around 70 to 80% of antibiotics, are used in animals rather than humans. Okay, so just keep these 2-3 points in your mind. This will help you to understand what I'm going to talk about. All right. So let's go to the main topic, that is causes and spread of ABR or AMR, right? So for your understanding, I've just divided these into 2 major headings. And don't worry looking at different multiple subheadings. We will go through each one of them in a very, very simple language. So the first category which I have put in are the causes of AMR, and that I've put in under the biological factors. And the second one is social factors. So the biological factors are the one for which microbes are playing the key role, and social factors are the one wherein humans are, making some contribution to raise this AMR. So let's just go through each one of them to understand how these microbes and how humans contribute to the situation. All right. So biological factors, as I've already told, microbes are the one who are, majorly responsible for biological factors, microbial factors. So these are the common terms. I'm sure nowadays this mutation word, it is very, very common. And I guess now, thanks, I don't know, should I say thanks or no thanks to COVID-19, but most of us know the term mutation, right? So just to give you a reglimpse of it, we have heard about COVID-19. We started listening about this term, very famous, into 2020, but then we heard about the variants, alpha, beta, delta. So you name a number or category, it is there in COVID-19. So what are those? Those are the changed variants of COVID-19, right? And that is making treatment more problematic or more difficult. Similarly, these microbes, they also undergo mutations, and when these microbes, they multiply, these genetic mutations, they occur, and they make these microbes resistant towards the antimicrobials. So this is one reason wherein microbes are contributing. Second important reason is selective pressure. So basically, if you see this diagram, you can see, I am not sure whether the size is small, but you can focus on the color coding. Don't focus on the content, just focus on the colors. You can see multiple yellow dots, okay, and couple of red dots. So these yellow dots, they represent the microbes who are sensitive to the drugs. By drugs, I mean the antimicrobial agents. But there are a few, like these 2 red dots, who are already resistant to the antimicrobials, right? So what happens whenever these are exposed to antimicrobials and some concentration is, some minimal concentration is given, the microbes who are being killed, they are fine, they are not there. But the microbes, sometimes they become more stronger, and they revise themselves with the help of resistant genes which are already present in them, and they come back with a more stronger form, and that procedure or that phenomena is called as selective pressure. So basically, it's when the microbes are exposed, their resistant genes also gets activated if they are there, and then they become more stronger to fight against or grow in the presence of antimicrobials. All right, and last but not the least, it's a gene transfer. As you can see in this diagram, there is a very cute blue color of bacteria, you can say, or a microbe, which is having some problem with it. You can see these blue circles on it, right? So this has made something, means it already has some genes in itself, right? And then these genes can be easily transferred to other microbes. So this is one of the major problems in case of microbes, because they can talk to each other, they can share the genes with each other, which is again one of the major reasons why this antimicrobial resistance is increasing at such high pace. So if you see, they start sharing the genes, and now this green bacteria, which was good bacteria or good microbe earlier, has now become the resistant microbe. So these are the three basic phenomena. So ultimately, you just need to remember, students, that these are the genes basically which are responsible for resistance. So either the microbes can acquire them, or they can underwent mutations, or they can have the changes under the presence of antimicrobials, which is called as selective pressure. All right. Okay, now let's talk about the social factors. So social factors basically are influenced by the humans. So these are again very, very simple things which I'm sure all of us know at some point of time, but we neglect them. So let's just revise them. One of the key reasons of this increased incidence of AMR is inappropriate diagnosis, right? So whenever you go to a physician or to a doctor, and you are suffering from some pain, you ask for some treatment, right? And again, I would not say this is a physician's fault. No offense to anybody from this profession. We all respect you, but at times physicians have to take some decision that they have to, prescribe you some antibiotics based on your symptoms. So then it is not a correct diagnosis, and and in the end, it results in the treatment or maybe prescription without the diagnosis of the correct organism which is responsible for that disease. Plus, there are many labs or many hospitals which don't have the facility for antibiotic sensitivity test. So again, you may end up, having the antibiotics which are against which your causative agent is already resistant. So again, it's a kind of a vicious circle. So inappropriate diagnosis results in the inappropriate prescription. All right. Then something which is again self-explanatory, as the name indicates, incomplete medication. So at times what happened, the doctor has done the correct diagnosis. Okay, just assume doctor did the correct diagnosis, lab reports were there, everything was there, but you didn't follow up the medication. So like Dr. Donna was mentioning, that Alexander Fleming, he there at that point of time, he already raised an alarm that if you don't complete the dose and you just expose the microbes to some lethal sublethal concentration, the microbes will adapt to a situation, and they will start they will learn how to grow in the presence of these concentration of antimicrobials. So what happens just to give you an example, whenever you take an antibiotic or antimicrobial agent, the doctor prescribes you for 5 days interval, but normally what we do, after third day, when we start feeling good, we feel okay, it's okay, let's not have it. Why to have more of antibiotic or more of drugs? These are not good. So you just don't complete those last 2 days of drugs, but those last two concentrations are very, very important to completely remove the causative agent or the bacteria or any other microbe from the system. Okay, so this further aggravates or creates a situation wherein the microbes can choose a platform of selective pressure, and they can do the gene transfers and so on and so forth. Another phenomena is self-medication. Again, the term is self-explanatory. So whenever you don't prefer going to a physician, you just think, okay, यही symptoms है. Last week जब कुछ किसी को problem हुआ था, या मेरे uncle के बेटे को ऐसा कुछ problem हुआ था, again this was the drug which was prescribed. Let's just take it. ठीक तो हो ही जाता है. So that should that is a case again which result in promoting this antimicrobial resistance. And last but not the least, in social factors, we have inappropriate use. So for this, I will use this slide. As I've already told, just keep in mind that antimicrobials or antibiotics, they are not only used in humans, they are also used in animals, plants, environment. So they are also everywhere. So in short, with the passage of time, what happened that we are using antimicrobials in humans, we are using antimicrobials in plants, in animals, again for the treatment of multiple infections, which is required also, but the misuse and like the different social factors which I just explained, all these factors, they contributed to one situation. And with the passage of time, what happened, these antimicrobials, these antimicrobial resistant organisms and these antimicrobial genes. So they just spread everywhere in the environment. So now we talked about the causes, right? The social factors, the biological factors, but there is a thin line between the emergence and spread, because the factors which are involved in the development of AMR, they are also responsible for the spread. So let us have a look on how these antimicrobials spread in the environment, right? So this is just a small pictorial diagram just to make you understand that how AMR spreads in humans. So just for your understanding, again, as I've already told, out of 10 antimicrobials, if they are in market, if 80% are used in or 70% are used in animals, the remaining 20% or 30% are used in humans. So what happens basically, whenever the humans consume antibiotics, right, or antimicrobials, so through their body fluids or body waste, because any antimicrobial agent, they are not metabolized completely into the system. Okay, so some bit of antimicrobial is excreted out into the body fluids or the waste, or maybe stool sample or urine sample or these kind of body fluids. It depends on the situation of a patient also as well. So anyways, so these antimicrobials as well as these microbes, again, because we have already discussed that wherever there are antibiotics or antimicrobial agents, there are chances that the microbes around those antimicrobials will start undergoing the selective pressure and mutations and other gene transfer, those kind of things, right? So whenever the humans are being exposed to these antimicrobials, there are higher chances that a human body will also generate antimicrobial resistant organisms as well as antibiotics. So both of them, both of these are released out of human body through waste, and then if they are not properly treated, they enter into the water channels. We all know this is a drainage system which is there, true for all the regions and parts of the world. So these enter into the water channels and soil. Further, if they are not treated properly, the same water and the same soil, they are being used for the plant farming. So in a way, from humans, it entered into the environment, and from there it entered into another sector of the environment, that is into plant farming. So basically all the plants and fruits and vegetables which are being grown on that land or water, they will also have those compositions, and it will again be consumed by the humans. All right, so I think that has set the base, so I can be now a little faster because I also have to stick to time. So if we look at the spread of AMR in case of animals, so this fact we already know, more than 70% of antimicrobials are used in animals. So what happens when again the animals, they consume the antimicrobials, again the same phenomena, they are also living beings, so they also have antimicrobial residues, they also have antimicrobial resistant organisms in their system. So in this case, in case of animals, either we take the products from the animals in the form of milk, egg, meat, or dairy products. So they are consumed, directly, and then through the human consumption, they are being transferred. Second way how animals are contributing, the animal waste. It acts as a fertilizer, it acts as the manure is being used. So what happens, again the same channel, this manure is rich in the antimicrobial agents as well as the superbugs, the term used for antimicrobial resistant organisms, and they are used as manure in agriculture. Again it enters into few fruits, and again it enters into the human cycle. Second last but not the least, the spread of AMR in plants. Again, it is more or less the similar thing. The only points we have to keep in mind is how it happens. The next cycle is same, but the key point is how it happens. So there are three ways. One we have already discussed, if the animal manure is used as a fertilizer. Second, that also we have already discussed, the runoff from the water channels, if that is not treated properly. And last but not the least is the direct application. Sometimes we have the plants who are suffering from some diseases like fire blight of pear and apple, and the bacterial spot of peach. So these kind of diseases, they have to be treated. Otherwise, the whole the final product will not be grown in a proper way. So just to ensure the quality growth, they put the antimicrobials directly spray on the plants. Okay, so last but not the least is the spread of AMR in the environment. Again, environment is a very big word, so everything comes under environment, I know, but just to here we just talk about the non-living things, mostly the examples which represent. So again, this part we have already discussed in case of environment, you know, the same antimicrobials, antimicrobial resistant organisms, they are entering into the system through animals, plants, aquaculture. This we have discussed. Now, these are two new things. So one is through hospitals. So in hospitals, you will surprise that how hospitals are there for us for our treatment, right? But hospitals, they also have many antibiotics which are not used, right? They have leftover antibiotics. And then those antibiotics, one condition is they are treated properly, you know, and then they are not entering into the water channels. But at times, because of lack of infrastructure or some other reasons, from the community as well as from the hospital sector, the antimicrobials and the antimicrobial resistant organisms, they enter into the water channels, the lakes, rivers, and soils. And same holds true for pharmaceutical industries, the industries which are making the antimicrobials. So at times they also have some metabolites or maybe some components which are being used for the formation of antimicrobials. So if they are also not used, like, or maybe there are some reactions and there are some leftover things, they are also directly, exposed or thrown into the these lakes, river, and soil channels. So in a way, I hope I am able to justify. And now you can easily this diagram, if you have understood anything which I was just talking right from last 5-10 minutes, I guess. So this must be a self-explanatory image right now, that antimicrobials, they enter into human system, they enter into animals, and how through human they are entering into water channels, and that is going into environment. Same from animals, it is entering into as a used as a manure, and animals are also feeding on the these food products, and these are also being directly consumed by humans. So in a way, it's a cycle which is vicious, and you cannot stop or maybe control anything with respect to one thing, because if you take care of animals, you cannot take care of the plants. If so the spread has to stop somewhere, and all the channels need to put some efforts, because aisa nahi kar sakte that you just purify all the water channels, but what if the foods or the manure is already contaminated with antimicrobials, and the meat product is already contaminated with antimicrobials, right? So it's a multi-sectoral approach that we have to take to take care of this situation. So yeah, one more thing which I intentionally wanted to highlight here, that what promotes AMR, in addition to all of the factors, like Dr. Donna was also mentioning, that poverty is one of the reason. And again, it is a vicious cycle of infection and poverty. I would also like to mention that in a country like India, which is a developing country, it has a huge population. And obviously, it is easy to control 10 people versus 10,000 or 100,000 people, right? So this huge high population, it plays a major role in promoting AMR, because if there will be more population, there will be more travel around the world. Again, this example is very, very famous whenever you talk about AMR in India. NDM1 strain, which started, which was first of all isolated from India. So the journey started in, I think, 2005, and then you can see how it's spread across the globe, right? So so more population, more is the travel, more are the chances of infection. And I think now these words are very, very common, and I need not to explain each and every word, because COVID-19 has already made us understand this situation, right? So we know that if there is more of communication among the population, there are more chances of infection. Plus, lack of education, that also plays a key role. And last but not the least, lack of infection and prevention control. Ab aisa nahi hai ki high population hai that we should stop communication. No, one of the easy way is also to take care of the infection and prevention control measures, but there is lack of those infection prevention control measures. As we know that there is lack of infrastructure, it needs a lot of money to be put in for the betterment of the health sector, so on and so forth. So as I've already mentioned, one of the key ways to take care of the situation is to break the cycle that, these all steps should not happen. But I guess another easy way is, this One Health again, this One Health is approach, as I was saying, that you take care of the human thing, animal thing, plant thing. So if all the sectors, they come together, this is one way that you deal with the situation with the help of One Health, wherein all the people, all the representatives from multiple channels, they will come together, they will sit and they will ensure that yes, water channels are also pure, the animal feed is also free of antimicrobials, the humans are also taking the fully prescribed antimicrobials. These are possible, but as you know, there are multiple steps to it, right? So another easy thing what we can do is alternate approach. If there is no infection, I know it sounds unrealistic, but if there is no infection, there are no usage of antibiotics, right? Or antimicrobials for that matter. Further, there are no chances of antimicrobial resistance. So this situation seems, I know it seems little unreal, as I've already mentioned, but this is possible, right? So in conclusion, I would just like to mention that microbes are everywhere. So are the antimicrobial resistant organisms and antimicrobials. Microbes cannot be removed because there are many microbes which are good for us also, right? Decompositions happen, digestions happen, and our normal flora is there, right? So microbes cannot be removed, but the spread of infection can be controlled. As I think, or we can say it in conclusion, that if there is less infection, there is less antibiotic consumption and there is less antibiotic resistance. It also holds true for antimicrobial consumption and antimicrobial resistance. And all this can be taken care with only one step, and that is infection control. So I am sure after going through today's session, you all will be able to know that what all are the measures that can fall under the infection control, so that infections, the root cause of the problem of AMR can be handled. So if infections are controlled, I think the rest of the things will already start coming into place. So that's all from my side. Any questions? I'll be more than happy to answer.
Thank you, ma'am, for the wonderful talk. You made it so simple to understand and assimilate. Actually, we have a few questions, but we are running a bit late. So maybe I will try to squeeze the questions somewhere in between the workshop for you.
Sure.
Right?
Sure. Thank you.
Okay. Thank you, ma'am. Now, I would like to invite Dr. Prakash Narayanan to discuss more about the strategies in place to fight this crisis of antibiotic resistance. Dr. Prakash is currently working as Associate Professor at Prasanna School of Public Health, Manipal Academy of Higher Education. His area of research includes communicable and non-communicable diseases, occupational health, reproductive health, mental health, zoonosis, drug resistance, and One Health. He has conducted more than 25 national level research studies in areas of infectious diseases. Warm welcome, sir. Over to you. And sir, would you mind if you keep your camera on?
Thank you. Yeah.
Okay, over to you, sir. Yeah.
So, good afternoon to Indian partners and good morning to European partners, listeners. And I would like to thank Amrita Vishwavidyalaya for giving an opportunity to discuss about this important topic, infection prevention control and the response to antimicrobial resistance. So that I'll start the show, and I would like to thank Dr. Kiranjit for setting up the ground, and so I need not have to go through many of my slides, and I run slightly faster. Okay, thank you. So these are the contents. I'd like to highlight some of the importance of tackling antimicrobial resistance. Process is already discussed by Dr. Kiranjit, and then I'll be just focusing a bit on the surveillance of antimicrobial resistance, and then moving into global action plan to control or contain antimicrobial resistance, national action plan on antimicrobial resistance, then state-wise plans, what is happening in India. I'm giving more focus on India, and subsequent speakers will be talking about their experience in Europe also. And then at the end, I'll be mentioning about some of the challenges in implementing the action plans and what could be the kind of measures we have to take to ensure the sustainability of such action plans. So I think it's already discussed by Dr. Donna and Dr. Kiranjit. So AMR is one of the top 10 global public health threats, and it takes a lot of lives and make them people disabled. Okay. And it increases hospital stays, duration of treatment, and loss of employment or maybe productive time, and need more expensive medicines and catastrophic expenses attached to the treatment. So, and as Dr. Donna mentioned in the beginning, I think we searched almost all the antimicrobes which is discovered so far. So we have to be very careful when we are taking antibiotics or antimicrobes and dealing with them. So that, I think, as Dr. Kiranjit already mentioned, it's proven health problems which can happen from health facilities, community, environment, and other animals and aquatic animals, plants, etc., and industries. Yes, so this is already mentioned. Briefly, the easy access to antimicrobes, antibiotics for antimicrobes, self-medication, over-the-counter sale of medicines, and lack facility to test the susceptibility of antibiotics in many of countries like India and all. And then different, physicians treat people differently, and people have inside doctors also don't want to take chances. So instead of providing first-line treatment with antimicrobes, they will start with second-line treatment or even higher dosages. These are all causes resistance to the antibiotics or antimicrobes. And then even if the treatment is correct, the medicine is right, then the dose, duration, route of administration, and the combinations with are based. So these are all may cause resistance. And then Dr. Kiranjit mentioned we have some mechanisms to regulate use of antibiotics, antimicrobes, and regulations for industries, for pharmaceutical industries, other industries. And implementation of such policies is what an issue that will be discussed a bit at length in the later slides. And then this particular, as mentioned by the previous speakers, it is a problem which to be tackled with the help of multiple stakeholders, multiple sectors, and the expectation of each of these sectors and the people varies, and the motives behind maybe promoting antibiotics, antimicrobes, or maybe business, agriculture, poultry, or we can say farming sector, or animal husbandry sector. So all those things, there are a lot of interest, different interests, and this use of antibiotics in other sectors already mentioned. So all those things are the major cause, and we need to find ways to minimize those unnecessary use of antimicrobes. And I just want to show the infographics by WHO. And so initially it's about the use of antibiotics, then second advice on those who are using it, and then who are the people who have a say over this in curbing antimicrobial resistance. So it's a general slide. So all the people have a stake to control antimicrobial resistance. So the hospitals and the laboratories, they all have a stake. And then I'll be talking about surveillance later, so I'll explain a bit more there. Then awareness creation. And awareness is not just for the general community or the patients or the people who are taking care of the patients. So, but awareness should be to all the stakeholders, all the people who are who can be part of this initiative of confronting antimicrobial resistance. And everybody has to take ownership of this particular issue, and it's a shared responsibility. It's not only the responsibility of hospital or the doctors or the pharmacist or the industry or the farmer who is producing. So it's a responsibility of everybody, and every stakeholders need, their role may be different, and we need to tell them how to go forward in this particular initiative. So the guidelines should be clearly laid down. And this antibiotic stewardship, anyway, Dr. Sangeeta will be talking in detail. I'm not going into that part, but antibiotic stewardship is another major topic, which will help in the infection prevention and control of antimicrobial resistance. And other sectors also are involved, and it is very important. And we need to change the policy. We frame the policies, implement the policies, and based on the evidences which is gathering through monitoring and evaluations, we may have to change the guidelines or update the guidelines. It's a kind of a continued activity. So that is in general. So as Dr. Kiranjit mentioned, it's a multi-sectoral, multi-partner problem. So I think, when the WHO or UNDP started with Millennium Development Goals, that, health for all. So that was a kind of motto. And now this One Health approach is what is, gaining momentum across the globe. And what we are seeing is, health in all. So whether it is trade, whether it is industry, whether it is labor, whether it's travel, tourism, hospital, pharmacy, everywhere. So health should be there in every policy. So that is kind of a policy shift which is happening at this point of time. And yes, not only the different people are involved, and the controlling of antimicrobial resistance needs different set of guidelines and programs for different people. And the hospital-based infection control and prevention is what Dr. Sangeeta is going to talk, and just giving an idea about different population groups or the kind of stakeholder. We need different types of measures to control antimicrobial resistance. Yes, and same, so physician, not only hospitals, when the physicians, veterinary things, and everybody have a role. And then yes, the hospitals, I think it's already going to cover. So with this, I want to say that as we use antimicrobes, and there's a chance that the resistance can grow, and the surveillance is one of the major way to identify the resistance, the presence of any resistant strains. So for that, we need proper surveillance mechanism. So we have different types of surveillance. It's called active surveillance, passive surveillance, laboratory-based surveillance. So different mechanisms are available. And so what is happening at this point of time is like those hospital which is having this stewardship program, they are actively into identifying the resistant pathogens. And all other places are like, say, tuberculosis program, revised national tuberculosis elimination program, national cancer prevention program, or even national HIV and AIDS control program. So those places, this passive surveillance. If the first line treatment is not working, then they'll move to a second line, or some places they'll start with second line. So there's no clear guidelines, or maybe not implementing the guidelines clearly, and there's no laboratory testing on the patients, or maybe or to identify is there any resistant strains in the body or not before they start treating. So that is concern. So surveillance is very important to understand and identify the patterns and the common pathogens, emerging pathogens, and what is the magnitude of this particular antimicrobial resistance in the community, or in the particular type of patients, among TB patients or HIV patients, or or so those things we can really find out, and that is important for planning and maybe providing treatment and support and management. Then, this will try to help in developing policies to minimize the use or misuse of antibiotics or antimicrobes. And plus, the surveillance will help to improve the quality, safety, and cost of healthcare services by hospitals as well as by the patients. And then understanding this resistance, will help us to strengthen our mechanisms and the technology that is required to identify certain type of resistant pathogens, and what could be the alternative or maybe next line of treatment options. So this is a kind of surveillance is always important to understand how the resistant pathogens are moving. With that, I move to how are we responding to resistance. So there are different action plan. So I start with WHO. So the World Health Organization and identified this particular problem of microbial resistance back in 1998 with World Health Assembly. They identified the expert committee cautioned about the misuse of antimicrobials and rational use of antibiotics and medicines. So then 2005, this international health regulations, there, I'll just go to that and I'll come back to the slide. So in national health regulations, they made containment of antimicrobial resistance as a strategic priority, and all the nation states are requested to report on antimicrobial resistance. And then subsequently it moved to Europe, US, Australia, Japan. So WHO helped developing or maybe asked or supported nation states to develop the policies. So in the context of infection prevention and control, There are, okay, I'm just putting only those, important policies or action plans related to infection prevention and control. Okay, so there, then, SDG goals, okay, Sustainable Development Goal, they're emphasizing on the use of or provision of safe water, sanitation, and hygiene. And then WHO, global and the Southeast Asian region came up with a patient safety program, and then guidelines on core competences of infection control program. So different guidelines came. And with that, 2015, the WHO, along with Food and Agriculture Organization and World Organization for the Animal Health, came up with an action plan to contain antimicrobial resistance, which is called as Global Action Plan on Antimicrobial Resistance. And it has got 5 main objectives, or you can say priority areas. So one is to improve the awareness on AMR through communication, means IEC, education and communication, and through trainings, okay, or teaching, say training, and then strengthen the knowledge and evidence-based base through surveillance and research, and then have to implement infection prevention measures to reduce the incidence of AMR incidences. And then it was promoting the optimal use of antimicrobials in human and animals, okay, including plants, we can say. And then develop, okay, capacity for research and maybe technology for identifying resistance, as well as developing new antibiotics or antimicrobes and vaccines, and so that we can minimize the use of prevention, basically preventive mesmerization, vaccination, and easy diagnosis or maybe early diagnosis, and so that we minimize the use of antimicrobes, as Dr. Kiranjit mentioned in the previous. Oh, my internet connection is unstable. Working? Thank you. Yeah. So then, along with this global action plan of 2015, I think many countries started their own action plans. All the European countries adopted this action plan, and then India also started, its journey towards, antimicrobial resistance, and there is India organized a conference on antimicrobial resistance in Jaipur in 2011 September, and all the member states, okay, they agreed on a declaration called Jaipur Declaration, and then subsequently a policy was framed by Union Government of India on containment of antimicrobial resistance in 2011, and the major components to implement or maybe to prevent or the infection or maybe the resistance are mentioned as surveillance, rational use of antimicrobials, then infection prevention and control program, and research on antimicrobials, as well as monitoring and evaluation. And later, in August 2012, a meeting was held in Chennai, and it is called as Chennai Declaration, and it's paved a roadmap to tackle the challenge of antimicrobial resistance. And then subsequently, certain policies being changed or maybe improved, and this containment of antimicrobial resistance was part of the 12th financial plan, and then this Schedule H drugs. Okay, these are the drugs which are supposed to be dispensed only by prescription and proper counseling or assessment of the necessity to use that particular medication. So that was there, then later now H1 and yes, other drugs also, the list of essential medicines came that was supported by WHO. I think WHO in 2017 came up with the list of essential medicines for use. So that was adopted by most of the member states, and India also adopted it. And in 2017, the National Action Plan for containment of antimicrobial resistance was adopted by the government, or I can say Parliament, and it is based on this One Health approach. And as part of international health regulations and WHO's effort to the surveillance of antimicrobial resistance, India started reporting a resistance, antimicrobial resistance data to the GLASS platform. And as per that plan, the plan India also used the same 5 strategies which is mentioned by the Global Action Plan. So all these 5 objectives were included in India's National Action Plan. And the last addition, in addition to that, India added one component called leadership. So that is the extra component. So it is aligning with the Global Action Plan. Okay, then yes. Before implementing this National Action Plan, the Government of India called for a meeting, and then sensitization and media campaign started. Name medicines with a red line. That was the name, and later interministerial consensus was taken, and then the state ministers meeting was held. Then this particular policy was rolled out in the states. So in India, as all of you might be knowing that, okay, health is a state subject, and central government or the Union Government of India, the central government will be providing the guidelines and 50 to 60% of the finance to implement the state plans, health plans. So the central government asked the states to develop state level action plan to roll out antimicrobial, or maybe to curb antimicrobial resistance. And so with that, I think, since it is a non-health issue, the government of India started networking with animal sector, you can say veterinary sector, and other sectors like food safety and standards authority of India, then drug control or controller general of India, and fisheries. So different sectors to make sure that this particular program is truly intersectoral and going to help implementing the initiative better. And so far, around 30 tertiary care hospitals across India have been identified to control the misuse and overuse of antimicrobial and antibiotics. Okay, and certain fixed dose combination antibiotics being banned, and similarly, certain antibiotics is banned by veterinary sector. And the Central Pollution Control Board came up with the guidelines on the disposal of the waste or industrial effluents from the pharmaceutical industries, as well as many other industries also pollute the water, and sometimes certain resistant strains can be there in the industrial waste. Yes. So with that, I think the recent idea of India, the government of India, is to start a National Institute of One Health in Nagpur for the prevention and control of zoonosis. But one of the major focus is antimicrobial resistance and its transmission between human to animals or animals to human. So that is there. And then states started implementing their developing their action plans. And many states are in different stages. Certain states, 3 states already started to adopt this state level action plan. And 9 states, they identified officials, and few states, the stakeholder sensitive session meeting is happening. And okay, so okay, yeah. So yes, so I just move. Okay, this Kerala action plan that was launched in 2018 itself, and the last priority, that is collaboration. I mean, Kerala government is focusing on public-private partnerships and integrated disease surveillance program to ensure the sustainability of the program. And another state which is adopted this state action plan on antimicrobial resistance containment is Madhya Pradesh. It was in July 26, 2019. And the major focus is governance. All the priorities will be tackled through better governance and fostering intersectoral and within sector coordination. And Delhi government adopted this plan in January 2020, and here intersectoral collaboration and intra-state collaboration is what is they are expecting. So with that, I think state action plan is over. So yes, some challenges are there. I'll just brief it. One is the varied multiple stakeholders, multiple partners, and various expectations, perceptions, and the reasons for antibiotic use or misuse can be varying and many, and the lack of facility to detect the resistant pathogens, and then the contaminations, as Kiranjit mentioned, the environment contamination by different sectors that we need to take care of: hospitals, pharmaceutical, other industries, agriculture, farming, fisheries, all those industries, all the people, all sectors may contaminate or maybe the environment. And then we have huge gaps in the infection and prevention and control across hospitals, across sectors. And the latest guideline by Niti Aayog of Government of India, there's a roadmap for SDG 2017 to 2032. They mentioned about even a stewardship program for the animal sector. And then they're saying, maybe similar stewardship programs might be required, in agriculture sector also. Agricultural universities and other institutions they are thinking about. So they mentioned about stewardships, not only hospital and veterinary and maybe agriculture sector. So that is there, and varying levels of this control in the institutions and multiple stakeholders, and unorganized labor and agriculture sector, and political and governance and leadership skills and priorities, and not last but not least, you can say budget is a major issue. And even though this particular policy is adopted by the Union Government of India in 2018, there's no budgetary provision or allocation is made for this particular important aspect of prevention and control of or containment of antimicrobial resistance. And on top of that, this COVID-19 changed the health sector priorities. So that is another issue. So,
Sir, Prakash
yeah.
sir?
Yes.
Sir, requesting you to rush up the slides, please. We are just running late.
Last two slides.
Yeah.
Yes.
Thank you.
Yeah,
Thank you, sir.
To some, for an effective, or you can say effective infection prevention, control of, or you can say containment of antibiotic or antimicrobial resistance, we need better political will, more resources, and context-specific or maybe localized guidelines, and then shared goals, and then strong governance, coordination, communication, and in the sectoral systems, as well as documenting the evidences. With that, I stop. I know I've exceeded our time by a few minutes, but anyway, I take this opportunity to thank the organizers. And any questions? Thanks.
Thank you, sir, for the interesting talk. Sir, can you please stop sharing the screen? Yeah, it was enlightening to us to know about whole lot of initiatives that is taking place, especially in India. And it is a ray of positive hope, I must say, that we can curb the crisis of AMR. Sir, we have a question for you, but I will try to address all the questions towards the end of workshop, since we are running a bit late. I need to catch up the timings.
Right.
Yeah. And participants, regarding the break, I am sorry to say that since we are running a little late, we might have to jump start to the next session, skipping the break. All workshop participants are requested to stay till the end of the workshop to be eligible for the certificate. All right, so now let's quickly take a journey into the world of antimicrobial stewardship. I would like to welcome Dr. Sangeeta Sudhir to discuss more about the need and implementation of an antimicrobial stewardship program and how did it change the scenario of resistance in a hospital. Dr. Sangeeta is working as the research fellow in ICMR CDC Collaborative Research Project at Amrita Institute of Medical Sciences, Cochin, Kerala. She is a key stakeholder in the antimicrobial stewardship program right from its inception in the hospital in February 2016. She has been instrumental in training pharmacists in antimicrobial stewardship across the state. Over to you, Dr. Sangeeta. Warm welcome.
Thank you, Dr. Dona, for your kind introduction, and thank you, whole Preventive team, Dr. Dona, Dr. Kiranjit, Sanjeev sir, for inviting me to speak on antimicrobial stewardship. So let me share my screen. So for today's topic, I will be covering the antimicrobial stewardship, its impact, implementation, various AMS strategies and AMS outcomes at Amrita. So as you all know, India is a highly populated country with a huge infectious disease burden. We have a very high consumption of antibiotics where humans consume more than animals. And the antimicrobial misuse is also quite high. We can, in every setting, even in the community or healthcare, either the drugs are unnecessarily prescribed or if it is inappropriately prescribed. Apart from this, we are living in a post-antibiotic era where there are no new molecules developed after 2010. And what is existing is all the molecules and the derivatives of existing molecules. And that is what put us in a pressure to save the existing drugs. And that is where the role of antimicrobial stewardship set in. Well, it is all about appropriateness of antimicrobial, careful and responsible management of antibiotics. So appropriateness, ensuring appropriateness through coordinated interventions and strategies. Well, it need not be a very complex term. It can be a simple intervention to optimize the drug to a well-structured and a well-implemented program. So we have been hearing a lot about the barriers of implementation of antimicrobial stewardship across the country. Yes, it is true that we have a very weak and overburdened infrastructure. We have gaps in diagnostics and surveillance. Even in the primary care settings, we don't have a microbiology lab. Even in tertiary care settings, we don't have a routine use of rapid diagnostic tests or other molecular-based tests. Now, there are gaps in policies. Well, even there are policies existing. Some of them are not effectively implemented. There is a lack of support from the management to do any stewardship activities. There is inadequate, and that's a stark reality that we are not having adequate infectious disease training of healthcare professionals across the country. But the reality is that some of these barriers are not just limited to India, but it is actually everywhere across the countries. Despite all this fact, there are success stories from India, and that is a highlight. So let's taking your attention to the implementation of antimicrobial stewardship in a resource limited setting. Well, stewardship can be implemented at any level. It can be a well-structured program. It can be implemented nationally, in a state level, in a hospital level, but it can also be implemented in a department level where you are posted. So there are various tools recommending tools for guidance and recommendation by CDC core elements and WHO antimicrobial stewardship toolkits, British Society antimicrobial chemotherapy recommendations, WHO aware index classifications, and these are some of the steps of implementation in a nutshell. So we will be discussing each of these in the coming slide. So, well, if you would like to find out any opportunity for doing an intervention in your setting, first thing we need to identify is that understand your situation, understand the level of appropriateness of prescriptions in your setting, even if it is in a department or a hospital. So what we can do is to do a prospective audit of the prescription audits, or retrospective surveillance, or we can also do a global point prevalence survey, which is actually a rapid, effective, and an easy tool. It's a one-time audit where, say, a team of professionals can go, say, on a day at 8 a.m., go to a ward and review the prescription for its appropriateness, whether it is appropriately indicated, the indication has been perfectly documented, whether it is according to the guidelines. So we will be capturing all these details on that particular moment, and it will be a reflection of a trend of antimicrobial stewardship in that setting. And this is how we draw conclusion out of a result. So in this case, we need to develop an antibiotic guideline. So let's see, this is a study from Amrita, where Amrita participated with 25 hospitals across the country. And a conclusion was drawn that a high level non-compliance to international guidelines exist. Now, for any successful implementation of a program, leadership support is essential. So unfortunately, we have a very good leadership support of our administrative champion and ID clinicians. Well, it can also be a senior hospital management or a team of skilled professionals who are adequately trained in infectious diseases. Now, another recommendation by IDSA and SHIA is that we need to have a core team members. So these are the ideal recommendation of a multidisciplinary team, but it need not be the same professionals. Anybody who's adequately infectious disease trained can actually bring about a lot of change. For example, we can have engagement of champions from different levels, like surgical champion, medical champion, a dental champion from a dentistry, a nursing champion, a public health professional who can help with policy making, IT professionals, and lot. But the thing is that each one of them should have a dedicated time, and the whole program should have a sustained workflow and clear lines of accountability. For example, the clinical pharmacist responsible to provide appropriate or accurate patient information. So any kind of misinformation can actually affect the credibility of the program. So there will be clear lines of roles and responsibilities for each team members, and that is absolutely essential for the success of the program. Now, so till now what we have did was we identified a opportunity for stewardship. We understand that we need a leadership support, we need a team, we need to have a structure of workflow. But for any intervention if we need to implement any interventions, we need to have effective and good strategy that is feasible in our setting. So it is not necessary that every setting will have equal resources, equally skilled professionals. So we need to tailor it accordingly. Okay, so you already know, you have already covered this strategy, front-end strategy, back-end strategy, supplemental strategies in your preventive curriculum. So pre-authorization is a front-end strategy. Well, this is a program where the doctor has to get a prior approval to prescribe an antibiotic from an authorized person in an ASP team, ideally. And then only then a drug will be dispensed from pharmacy and will reach to the patient. But the problem is that in this case, there should be a 24/7 service. There should be adequately trained, highly skilled infectious disease professionals. So in India, we don't usually see pre-authorization. It's not very common, and it is one of the major challenging tasks. However, at Amrita, we have tailored it and has selected based on department and selected based on antibiotics. So ceftazidime, avibactam, and colistin are the two antibiotics which have been selected. And there has been a system has been implemented along with the pharmacy that there will not be any delay in obtaining the medications, even when there is an off hours. Now, prospective audit and feedback is the one which we majorly do for our rest of the antimicrobials. And this is a major strategy we commonly see in India. Well, at Amrita, this is our workflow where clinical pharmacists, it's a physician-led clinical pharmacist-driven program where pharmacists will generate a list of reserved antimicrobials every morning and will be reviewing the patient records. Will be going to electronic medical records, patient files, and sometimes we will also be interviewing the doctors if needed. So we will be reviewing the appropriateness of prescription and discussing with the ASP team members on a daily basis. So that will be infectious disease physician, microbiologist, and administrative champion. And once we've identified there is an inappropriateness, we will be filing recommendations. We'll be providing these recommendations to the primary care team over phone, as well as filing this recommendation in the patient file. The clinical pharmacist then review these recommendations for compliance, and then we'll be following up the patient till discharge or death. So what is really need to understand from this is that for any successful program, consistency of the meeting is important. There should be accurate patient information, as I already mentioned. There should be a prompt follow-up, and the communication, the feedback, the justification of the feedback is absolutely essential. Why you are providing the feedback? What did you identify? How will it help? And what are the evidences? This should be clearly communicated with that primary clinical team in order to have that compliance or acceptance. So this is another method of prospective or providing a feedback. So one of the barrier we have faced during our journey was an opinion from a clinical care team that the process we are doing was a closed room approach where we are not directly dealing with the patient and they are not ready to accept our recommendations. So that barrier was overcome by engagement of a clinical ID physician in the ASP team. They started rounding the patients. And this is such an example. This handshake stewardship is where any of the team members, it need not be a physician, it can also be a well-trained skilled and expert clinical pharmacist or a nurse or a physician, or it can be anybody, okay, but who should be absolutely and adequately trained, who should join the rounds. We will be joining the interdisciplinary departmental rounds, and they'll be providing that there will be a platform for bi-directional feedbacks, and any query can be cleared then and there itself. So this found to have much more acceptance. This is an example from a children's hospital in Colorado. Now, education is also very important. Education of the healthcare professionals. Well, we have had lot of opinions that international guidelines cannot be implemented in our setting. So antibiogram-based facility-specific treatment guidelines is one important measure where it is true because the susceptibility pattern is different in different settings, and therefore we need to have an antibiogram-based institution-specific guidelines. Now, departmental meetings are a form of education, sensitization programs, local, national, international conferences, continuing medical education, incorporating AMR, antimicrobial stewardship in UG and PG curriculums. And that's what Prevented is currently doing. Now, bundle-based approaches is yet another fantastic area. Well, sometimes the guidelines dissemination might not be helpful. So this was the case when we saw a lot of candidemia cases, and the physician were in the perception that Candida were considered as contaminants in the blood, but actually it's a life-threatening infection and should be immediately managed. And what we did was we made a bundle that is guidelines in a nutshell, and and this is also an example where microbiology provided a critical care alert. The critical care alert, once the organism is identified in the lab, that is immediately informed to the SP team members, and one of the team member is a clinical pharmacist or anybody, it can be anybody, who will be discussing it with the clinician. The bundle checklist will be filed in the patient record and ask the clinician to fill in the checklist. So with this, we were able to improve the management of candidemia patients better, the appropriateness improved, and there was a reduction in the mortality rate. It contained almost all the steps like prompt management of prompt initiation of antifungal, removal of central venous catheters, sending culture after 48 hours, or discontinuation of drug after 14 days of negative culture. So it included almost a comprehensive management. Now, another area where how stewardship, antimicrobial stewardship played a major role in outbreak management. So this was an example of an integration of antimicrobial stewardship along with infection prevention and control practices. So a checklist was made and this was implemented, and the stewardship team members and the IPC in hand were able to contain Candida auris. So diagnostic stewardship is yet another area where we can do a lot. Well, it is a wide area. So we have a lot of opportunities to do interventions here, right from the patients getting admitted till discharge. So you can see if at this point where the patient comes with a sign of infection, we need to identify whether it's a bacterial infection or a viral infection, if it is really an infection or a non-infectious etiology. So for example, if we have a rapid strep test and it is negative, we can obviously discontinue the drug then and there itself. Now we should also ensure that before starting an empiric therapy, a culture is sent, and this culture should be appropriately sent, whether the culture is indicated or not, and if it is appropriately collected, because in certain cases like infective endocarditis, we need 6 bottles of blood. And that should be, this paired culture should be taken 1 hour apart. Otherwise, we will not get adequate yield, and there will not be positive culture, and the empiric therapy will continue. Okay, and also early streamlining of antibiotics. And we have a lot to do during this pathway in diagnostic stewardship. Well, there has been a checklist was being introduced in order to ensure appropriateness of sending culture, and a policy was introduced mandating dual bottle policies in volume for blood cultures, infective endocarditis protocol, urine culture stewardship. So these are some of the examples from Amrita. Now there are various low-hanging fruits which are easily implementable by engaging champions. So this was an example where nursing champions were empowered to alert the physician to give loading dose of reserved antimicrobials, and we could reduce the inappropriateness from 19% to 5%. This was a collaboration with the PharmD interns, where they are already posted in departments, and some of the pharmacists were given asked to do a meropenem dose adjustment on a daily basis, and that was also found to have been very useful. Hang time. Hang time is a difference in the time. Okay, we have seen in many cases where a doctor will prescribe an antibiotic or any drug, and the drug will be arriving. The drug will be dispensing from the pharmacy, and it will be reaching to the patient after 3, 4, 5 hours. For in some cases, like sepsis, the antibiotic should be given within 1 hour, and mortality increases by 7.6% for every hour of delay. So this was a study. This was an attempt by the SP team members where they started noting the time of prescription and then the dispensing, the time of administration of drug, and found to have a very bad results. And they communicated it with the higher committees. They made some intervention, education models, and other toolkits. And finally, they could improve the percentage compliance to hang times less than 1 hour. Therapeutic drug monitoring is an area where we need to have some kind of pharmacokinetics dynamic skills. Currently, it is being done by clinical pharmacists across the India and almost everywhere worldwide. So it includes right from developing a TDM guidelines to sensitization of healthcare professionals to empowering, they are empowered. Clinical pharmacists are empowered to interpret the dose and adjust the dose accordingly. And this will be communicated to the residents and doctors to optimize antibiotics. And this is happening in our hospital, especially for the glycopeptides. There are various other supplemental strategies like clinical decision support system, which is a wonderful, and it's like an electronic medical system where we can do a lot of stewardship activities, but currently it's very rare in India. It's not very common because in clinical decision support system, there will be alerts for the doctors to send a culture before prescribing an antibiotic. We can incorporate some anaerobic, double anaerobic coverage. Certain things can be pre-implemented so that, pre-introduced so that there will be alerts and automations in the system. Rapid diagnostic test-based stewardship is also another example. IV to oral conversion, antibiotic recycling, and we have a very lot to do. So for any process to have an improvement, we need to have a measurement. So we need to measure for any process to improve. Just for example, process measures like rate of appropriateness, rate of escalation, de-escalation, rate of appropriate compliance. Well, in other case, the antibiotic consumption based on DDD, DOT, cost, length of stay, mortality, readmission rates. So all these are absolutely important, and this should be clearly communicated. It can be communicated on a department level. If you're doing it in a department level, it should be informed to all the healthcare professionals in your department. If it is in a hospital, it should be discussed with all the relevant stakeholders. It can also be implemented in a national and a global level. But what is the real importance is that while we communicate, there will be a transparency in the program, and there is a high likelihood of acceptance. And we will get a much more better buy-in from the clinician leaders, and we can also do this for quality improvement and research purpose. So just to give a brief insight on the outcome of antimicrobial stewardship at Amrita. So the program started in February 2016, and the program started with just 3 antimicrobial, auditing 3 antimicrobial, and it expanded a lot. It is a physician-led and a clinical pharmacist-driven program. And from 16 to 21, the appropriateness has actually improved to 91%. Now, coming on to the antibiotic consumption, by 2021, almost all the drugs, majority of the drugs has seen a reduction in the consumption and with a huge cost savings. Coming on to the antimicrobial resistance rate, carbapenem susceptibility almost commonly. This is a common drug, and to the common organism, the susceptibility improved. Now, from 2016, as I mentioned, from 2016, there had been a lot of evolution of the program. The team expanded, the process expanded. We added a lot of other challenges like the anti-tubercular stewardship, pediatric stewardship, antifungal stewardship, outpatient stewardship. So all these were physician-led and clinical pharmacist-driven program, but it may not be a clinical pharmacist as such. Because anybody who's really trained, who has given taking that accountability and responsibility, can introduce anything in any setting. So we have got a very good leadership support from our administrative champion, Dr. Sanjeev K. Singh, and he has been contributing a lot in designing and implementing antimicrobial stewardship model across the state of Kerala, and he has been involved in various providing technical expertise in developing Kerala State Action Plan and various strategies to tackle AMR nationally and internationally. With saying that, I'm concluding my words. Thank you so much.
Thank you, Sangeeta, for sharing your experiences in implementing a successful antimicrobial stewardship program. Implementing AMSP is possible even in resource-limited setup, and your talk proved that. In our fight against AMR, every action counts, and you proved that. So thank you so much, Dr. Sangeeta. Antimicrobial stewardship goes hand in hand with infection control practices. Thus, it becomes imperative to know more about infection control. And for this, we have our expert speaker, Dr. Carlos Parlos, on board with us. Dr. Carlos from Portuguese Catholic University is the coordinator of the Infection Control and Antimicrobial Committee of Hospital Beatriz Angelo and Grupo Luz Sode. His research interests span the areas in antimicrobial stewardship and antimicrobial resistance, infection prevention and control, e-health and education. It gives me immense pleasure to welcome you to the workshop. Over to you, Dr. Carlos.
I thank you very much. I know, sorry. Yes, thank you very much for your kind invitation. It's for me a pleasure to be again with you. So this was a talk that was initially thought to be done at Milan almost 2 years ago, so just before the COVID pandemic. So we have this delay, and now we are getting back to some normal. So thank you for this invitation. It's an honor to be with you. So as you said before, I'm here because I'm a teacher at the Catholic University of Portugal in Lisbon. And in fact, I teach for the nurse degree in the Institute of Health Sciences, but now the Catholic University of Lisbon has also a faculty of medicine. So just one advance comparing to the last talk last year. And this is my hospital. So my hospital is a 10 years old hospital. It is a general hospital with 425 beds. It's near Lisbon, the capital of Portugal. And in fact, it is an hospital accredited by the Joint Commission International, and it is a paper-free hospital, which allows us to have workflows and other solutions with interactive tools for example, antimicrobial prescription and also infection prevention and control. So my talk will cover some topics: the infection prevention and control at a glance. Then we move on to the prevention of transmission of microorganisms, and finally to the good practices on invasive procedures. We can define infection prevention and control as a current set of activities designed to reduce the incidence of healthcare-associated infections and improving quality and safety of care. So infection prevention and control, as also antimicrobial stewardship, in fact, are quality and safety issues. And in fact, these activities should be coordinated by integration of infection control and antimicrobial resistance committees, which should include physicians, nurses, pharmacists on their core, and of course, people from the management and also from the facilities and so on. So in this paper, which was published on the American Journal of Infection Control, these authors defend, in fact, that there should be a synergy between antimicrobial stewardship and infection prevention, because most of infections, or at least a great part of the infections that appear at the hospital, are in fact caused by resistant bacteria. And when we are talking about infection control and antibiotic stewardship, we can imagine this building with several pillars. So the prevention of bacterial resistance emergence through good practices of antimicrobial use, as we saw before, the prevention of the transmission crossed between patients, the transmission of bacteria, and not only bacteria, but also viruses and other organisms. good practice on invasive procedures, and there is also a pillar which is only for the people of management and infection control committees, which is dedicated to the issues on education, monitoring, and auditing. And all these pillars are based on what is the culture. So the culture is in fact what we do, what we think, the way we believe, the way we behave, and it's based on beliefs, rituals, attitudes, heroes, and symbols. And of course, the most important is in fact what we believe on. I will skip two of these pillars. So I won't talk about the issues related to bacterial resistance, emergence, neither with education, monitoring, and auditing. And also because we are talking to students, I won't talk, I won't cover other issues, just like, for example, issues related with facilities and hygiene, which are in fact very important, but I will cover mainly the topics that are related to our behavior and what we can do as physicians. So how can we prevent the transmission of microorganisms? We know that microorganisms are everywhere, as it was said before, and not only with our own bodies, which complies the microbiome, but also within or over all surfaces. And we know that all surfaces are colonized by bacteria. Some of these bacteria are resistant bacteria. So, and hygiene is in fact the most important activity that we can do to curb the transmission of bacteria. And we must always remember Ignaz Semmelweis, that in the 19th century in Vienna, Austria, he implemented an anti-hygiene program, and in fact he had a reduction of infections and mortality in the puerperal women. And we know that hygiene is done or should be done in 5 moments, which were defined by the World Health Organization. In fact, the hygiene program is the first challenge of safe patient safety developed by the World Health Organization. So all you know that before touching a patient, before cleaning or aseptic procedures, after exposure to a body fluid, after touching a patient, and after touching the patient's surroundings, what we call the epidemiologic bubble, we should do our hand hygiene. And it's not only important to know when to do that, but also how to do that. So we can do that with soap or alcoholic solutions, but independently of what we are using, we have 7 steps that must be covered always in the hand washing, in order to not to spare any part of the hands and all the fingertips, because these are the parts that are always or most always forgotten when we are doing an hand hygiene without thinking that we are doing a correct hand hygiene. And also, as I told you before, so we can use alcohol-based solutions, which are the mainstay for the most of the practical in the healthcare, or we can use soap or disinfectant soap and water whenever the hands are visible soiled, or whenever we are in the presence of a Clostridioides difficile infection, where the alcohol-based solutions is not so effective as the soap and water. And one very important issue is don't forget, please don't use these. So if you use enamel and gel, you are making impossible to do a correct and appropriate and hygiene. So there are some studies, some of them are there, that show that if you have these devices, what happens is that your hand hygiene will not be appropriate, and we will remain with some bacteria, some of them multi-resistant bacteria in your hands. And it's important to know that physicians, you are student physicians, all over the world, they are the ones that do not comply with the hand hygiene procedures. So we comply less than nurses. So these are the physicians, it's in Portuguese, médicos, less than nurses. And even auxiliary people have better results in terms of hand hygiene. And we can imagine, and we can ask, why does this happen? And it's something that is cultural, because nurses start to learn this need on their undergraduate, pre-graduated teaching, and physicians not so much. So, for example, the example or the reason of lack of time is not so very, very great reason, because nurses touch the patients much more than we do, we physicians. So they also need to have more time to do that. So, but they comply better. So please don't forget this. We must be an example for the other healthcare professionals. And when we look at the moments that are defined by the World Health Organization, we can see that the fourth moment, that is after touching the patient, is always better than the first moment, that is before touching the patients. So what we can conclude from this is that, in fact, we try to prevent, to protect ourselves and not to protect our patients. And I can tell you that I feel, and the studies will show that, for example, in the COVID pandemic, the use of personal protective equipment was mainly for the self-protection, and sometimes forgetting the isolation procedures and other things that are for the protection of the patients. So don't forget that the first moment before touching the patient is the most important moment, because you should not carry on bacteria and virus to your patients. Another way of doing the prevention of transmission of bacteria is to detect early the patients that are colonized when they arrive at hospitals. So this is the emergency room of my hospital. And when a patient arrives, not only at this emergency room, of course, but in all parts of the hospital, what we try to know is what are the bacteria that he is carrying on. So the screening and isolation is something that is very important. Was published, this strategy was published by Evelina Taponelli some years ago. And in fact, we need to know by risk assessment and screening, we need to know, for example, if the patient is high risk of being colonized with MRSA or carbapenem-resistant Enterobacterialis, and this should be done on hospital admission, because when the patient arrives to the hospital, he is already entering in the hospital ecosystem on special units admission, before surgical procedures, and during hospitalization, whenever there is a contact with colonized or infected patients, prolonged antibiotic course, etc. Don't forget, and you know, that one of the major problems and challenge that we have now is from carbapenem resistance Enterobacterialis, which is mainly related to exposure to healthcare and antimicrobials, and outbreaks have been observed in long-term care facilities, and that several antimicrobials, including carbapenems, cephalosporins, fluoroquinolones, and vancomycin, are implicated in the emergence of carbapenem-resistant Enterobacterialis. So what we do, because we are a paper-free hospital, is that every patient that is admitted, independently of the place of admission, and this is mainly done at the emergency department before moving on to the wards. So every patient, every physician has to fulfill an electronic questionnaire on admission, which has several questions that allows the system to know if there is a risk of colonization for at least MRSA and carbapenem-resistant Enterobacterialis. And these are, for example, if the patient was admitted at least during 3 days in the last months on an hospital or an home care facility and so on. If the patient has an important, significant epidemiologic microorganism on the last 6 months, if the patient, for example, is on dialysis, chemotherapy, and so on. So this automatically put the patient on isolation. And just to tell you that we have also questions for the suspicions of tuberculosis, and also for COVID, which is not here because this is a print screen which was not updated, and for diarrhea, which is associated with antibiotics. So the result is that, according to the answers, the system will automatically and independently, what is your knowledge, will implement the isolation procedures, and also it will put the swabs automatically, and automatically also it will send an email to the Infection Prevention and Control Committee, and this allows the infection control nurse and the site manager nurse to put the right patient in the right place. And also to start decolonization. And we do only decolonization for colonized MRSA patients. We do it with mupirocin and chlorhexidine during 5 days. And after that, we confirm the decolonization with 3 negative results on 3 consecutive days. Patient isolation is also a main strategy, because you know that in the perfect world, all we should do the correct things. But we know that the perfect world doesn't exist, so we need to create additional barriers between patients and other patients, healthcare workers, visitors, students, and the environment. And this is the isolation procedures. They are usually made in order to prevent the transmission from those patients to the other patients, but sometimes they are used in order to protect the patients themselves, what you call the protective isolation. So we isolate infected or colonized patients. And just to tell you that colonized patients are patients that have the bacteria, but they don't have signs of infection. So the difference between an infected and a colonized patient is that infected patients should be on antibiotics and colonized patients should not be. But for the purpose of the infection prevention and control practices, it's the same, the risk is the same. So if you are colonized, you are a risk for the other patient. So you are isolated as if you were infected, okay? So we do isolation for MRSA, carbapenem-resistant Enterobacterialis, VRE, vancomycin-resistant Enterococci, Acinetobacter baumannii, resistant to carbapenems, Clostridium difficile, and norovirus diarrhea. And you could put on isolation also the ESBL Klebsiella, respiratory tuberculosis, respiratory virus, meningococcal meningitis, measles. Don't forget measles, because measles has a potential of transmission and severity that is similar to the SARS-CoV-2 or even greater if you are not vaccinated, Ebola and MERS and so on. So the guidelines that we use are in fact the ones that were developed by the CDC originally in 2007. Of course, these guidelines have been updated at any moment, and in fact they are online, so you can consult by the microorganism, and the guideline shows you what to do.
Sorry to interrupt in between, Dr. Carlos.
Yeah.
Could you please rush up the presentation a bit?
I didn't understand, sorry.
Could you please rush up a bit the presentation? Like we are already running late.
You want me to stop the presentation?
No, you can continue the presentation, but maybe you can rush a little bit.
Okay, yes.
Yeah.
So,
thank you.
Yes. Thank you. Sorry. So just to remember we have contact isolation, droplet isolation, aerosol isolation or airborne isolation, protective isolation. And for the different microorganisms, you have the different use of personal protective equipment, okay? And some messages are here. So we must comply with strictly with the recommendation of isolations. And once again, physicians do not do this as well as, for example, nurses. So we have to improve that. So, of course, when we are doing an invasive procedure, we are also potentiating the development of an healthcare-associated infection, and so needing more treatment, more antibiotics, and so more resistant bacteria. So when we do invasive procedures, we have risks for the patients, as you can see here, and also risks for the executants. For example, the accidental exposure to some virus. And when we do an invasive procedure, the first thing that we need to know is if there is a strict indication for the placement of an invasive device. Are there alternatives? And then we need to reevaluate daily the indication for the device and to remove it as soon as possible. Don't forget that your patient is not, for example, the pneumonia patient is a patient that has some devices. So every day you need to ask yourself, does my patient need the device? When placing the device, so don't forget, for example, the use of adequate personal protective equipment and the adequate technique according to the procedure. And helpers, observers, and remaining staff should be wearing a surgical mask when they are at less than 1.5 meters. because of the importance of urinary catheterization, which is overdone, I always share with you these recommendations of indications for catheterization, which are made by the CDC. And please don't catheterize your patients routinely, and mainly the older patients, because most of older patients are already colonized with bacteria and in their bladder. And whenever you put a catheter, a urinary catheter, you try to transform a colonization on an infection. And we also implemented a protocol of nursing removal of the urinary catheter without the need of assistance or the need of authorization of the physicians. So this has dramatic results. And we can see here that after the implementation in the hospital, we just half the rate of urinary tract infections. And don't forget also that surgery is a major, is in fact the major intervention that we, when we invade the patients. And the World Alliance for Patient Safety has this second global patient safety challenge, which safe surgery saves lives. So just for finishing, better hand hygiene and isolation procedures. We need that. We need to do more risk assessment for search and destroy or search and contain resistant bacteria in our hospitals, starting on the admission. We need to have good practice on invasive procedures in order to not infect the patients. And in fact, my last message is the fact is that we need to change. There is a time for change, not only on antimicrobial stewardship, on antimicrobial prescription, but also in our practices, in our daily practices, in our contacts with the patients. So thank you very much. My hospital is an esteemed center, so you can do these observerships if you are a member of this society, which is the European Society of Clinical Microbiology and Infectious Diseases. So you can apply. We have been involved in some activities at an European level, and I would like to invite you to come to Lisbon, because in 2022, the Congress of this society will be at Lisbon. So it will be on presence and not, we hope, just online. Thank you very much.
Thank you, Dr. Carlos, for such a fantastic talk. You enlightened us with the hand hygiene and isolation practices in an hospital environment. And I do agree that we need to prioritize risk assessment for search and destroy or search and contain resistant bacteria. Thank you, sir, for the wonderful talk.
Thank you very much for inviting me.
Sir, please be with us. We might have some questions to answer by the end of the workshop. To curb the antimicrobial resistance crisis, in addition to the strategies taken in the healthcare sector, we need to do our bit in our community out there. To address this part, let us welcome Mr. Joydeep from the NGO Voluntary Health Association of Tripura. He is currently working as coordinator of the NGO, and he completed his diploma in pharmacy and diploma in ear mold technology. He has 11 years experience in the field of pharmaceutical drug. Welcome, sir, and over to you. I will start sharing the screen, sir. Is it visible, sir?
Yeah, it's visible.
Yeah, please, sir, over to you.
Yeah, thank you all. Thanks for giving me a chance to be a speaker in this program. So I will discuss about the role of NGOs in preventing and controlling antibiotics resistance in community. So what we can do, we as an NGO, what we can do. We are doing advocacy We are doing advocacy. That means we are awareing, we do something to aware the community. So the community should know if what is antibiotic, what's the use of antibiotic, and what they should do. In USA, a mass media campaigning was conducted to reduce overuse of antibiotic for outdoor advertisement. During India in 2018, Superheroes Against Superbugs, school children developed comics on various aspects of AVR and used these comics to influence the community. Mainly, school children are there to aware the community. Such Bharat Abhiyan, Clean India Mission. This is the another part where the government launches this Swachh Bharat mission in the year 2024. So what's the main objective of the mission? The main objective of the mission is to 4 Rs, that is reduce, reuse, recycle, and reuse. Argument of capacity at the local level to improve solid waste management, especially we are focusing on solid waste management in Swachh Bharat Abhiyan. Next, household waste management. So how we can household waste management? Waste to be segregated at 3 groups. In red bin, we use for domestic hazard wastes like cleaning agents, acids, GTT, phenols, etc. The green bin, we are used for biodegradable wastes, food wastes, fruit, vegetables like this. And the blue bin, we used for dry recycled waste like aluminum foil, plastic, glass, etc. Next, techniques of waste management in community. So how we are awareing the community, we are giving them some tips how you can reduce the wastes from the environment and make the environment clean. So one process is land filling. This is the very basic process. Maybe all you should know about this. But when we go in the community people don't know much about this type of things, how to manage the waste. And the wastes are related with antibiotic resistance. So in case of land filling, we are giving them idea about the technique. Land filling, burying the wastes in abdominal unused land and covering it with layer of soils. Then the second process is composting, process of converting organic waste such as leaves and food scraps into a valuable fertilizer. Composing, intercepting, destroying waste by material by burning in a disciplined way. See, the way is the disciplined way, because if we not burn the leaves and the other wastes in a disciplined way, it can also cause environment pollution. So we should follow the disciplined way. The another is recycling. Recycling means transforming waste material into raw product. We should encourage them to transform the waste materials into raw product, which can be used further for the use. Next, what we can do if we are a general public, if we are a health worker, what we can do. In case of if we are a general public, we should use only the prescribed antibiotics by a certified professional. Always take full prescription even if you feel better. That means if you feel better, you shouldn't stop the antibiotic. This is the basic concepts about the antibiotic. Never use leftover antibiotics. Never share antibiotics with others. This is the another main thing. The antibiotics prescribed by a registered medical professional, by a doctor, especially for the person who is getting the treatment from him. So we shouldn't share antibiotics with others. Prevent infections by regular washing your hands, avoiding contact with sick people, and keeping your vaccinations up to date. Keeping vaccinations up to date is very important. If we are a general public, we should update our vaccination. If you are a healthcare worker, prevent infection by ensuring your hands, instrument, and environment clean. The environment cleaning is the main thing. The health worker also should be a part to clean the environment, because in hospitals, in healthcare centers, they should clean everything. Keep your patients' vaccinations up to date. Health workers, if you think a patient might need antibiotics where possible, test to confirm and find out which one. That means if you are working as a health worker, and if we are working as a health worker, we should prescribe a proper antibiotic. Prescribe and dispense the right antibiotic at the right dose for the right duration. The duration, the dose, and the antibiotic type should be the perfect one. Next, rural practitioner. What rural practitioner should do? Avoid prescribing antibiotics for viral infection like flu, because the thing is that most of the rural practitioner, they don't know the antibiotics only use in case the disease is caused by the bacteria, not by the virus. So avoid practicing antibiotics for viral infections. So we are when we are arranging camps, when we are visiting the rural for our camps, so that time we are awareing them regarding this. Avoid use of multiple antibiotics. Do not prescribe antibiotics without correct diagnosis. Give clear instructions to patients about completing antibiotic dose, avoiding sharing of antibiotics, these things. In case of pharmacists should dispense antibiotics only under the prescription of a registered medical practitioner. And pharmacist also should give a clear instruction to the patient about the intake of antibiotics, including dose, avoid sharing of antibiotics. After the doctor, pharmacist is another healthcare professional who should avoid providing antibiotics of human consumption for animal use. The antibiotics are different. Next, in case of ASHA and Anganwadi worker, that means the grassroots level health workers, they should spread awareness about the AVR during the home visits. When they visit the home, they should aware, and they were awareing, promote vaccination, counsel the patients to give antibiotics to children only under the prescription of doctors, counsel the educate pregnant women regarding wise use of antibiotics and prevention of antibiotic resistance. In case of school teacher, what school teacher can do? School teachers should educate students on AVR and appropriate use of antibiotics. Initiate short talks on AVR during parent-teachers meeting. Organize events and activities on AVR. Include AVR-related articles in the school's magazine or libraries. Include basic AVR training as a part of curriculum. So that teacher should do in school to aware the student. Next, member of community-based organization. If you are a member of community-based organization, what should do? Orient PRI members about AVR, because PRI members directly interacting with the public each and every time. So they should aware and they should know about the AVR. Organize awareness classes, campaignings through reels and public talks, street dramas, videos, etc. And this develop group-specific communication programs, illustrations, standardized information, booklets, posters, etc. in local language. What farmers should do to stop antibiotic resistance? Farmer prevent AVR by maintaining hygiene, clean farm, fish tank, water storage, and equipped regularly. Maintain personal hygiene. Keep animals, housing, and outside area clean. Store feed at dry and safe place. Vaccination Vaccinate in consultation with your vet. Separate animals when they get and seek veterinary advice. See, when we are working with the farmers, we are awareing them when an animal is getting sick. So separate this animal from the other because bacteria can spread easily from one animal to other. Use antibiotics only under doctor's prescription because if they use more and more prescription, more and more antibiotics uh, to their livestock, so it can harm us also directly or indirectly. Adopt and share the best practice. Follow. Next. A PRI member, what a PRI member should do in agriculture sector, ensure appropriate use of antibiotics, conduct exhibitions to spread aware about AVR, animal husbandry sector, emphasis reducing misuse of antibiotics in feed, restrict over-the-counter medicine practice, promote vaccination activities, sanitation and hygiene, proper utilization of funds under the sanitation head. The PRI member should properly use the fund which is given for sanitization head, ensure adaptation and sanitization and waste management practice in the community. The PRI member is the only person who can easily ensure these things in the community. Next. Thank you all. This is my presentation. I will not take more time. I will thank you all.
Thank you, Joydeep sir, for the presentation. It was an interesting talk, and we understand that each and every person in the community can contribute to fight AMR. Such a collective effort will definitely yield result. Thank you, sir.
Thank you.
It was a wonderful experience to be at this workshop, gaining knowledge on various aspects of AMR. I would like to thank each and every one of the participants for taking the time out to attend this workshop. We will be providing e-certificates to the participants. I would like to request Ms. Varnika, the project manager, to share the link to the Google form in the YouTube chat box. Kindly fill up the Google form. Your e-certificate will be mailed to the email address provided in the form. Meanwhile, we received a few queries during this workshop. I'm sorry that I cannot attend to all the queries. I will just take up one question, and I would like to ask that question to Dr. Carlos. Dr. Carlos?
Yes.
Doctor, there's a question to you. According to you, how can one integrate antimicrobial stewardship and IPC, or infection prevention and control, in a hospital setting to curb AMR? What are the strategies?
Yes, so I think the main strategy is to have a single committee instead of two separate committees. So that doesn't mean that I am, as a physician, am doing exactly the same things that the nurses are doing. But we are working together, and for example, sometimes they find some information that is relevant for me, and vice versa. So if we work in the same committee and we do receive the same information, we can improve and leverage the integration of both antimicrobial stewardship and infection prevention and control. So my strategy is, please work together and create an integrated committee. So in order to improve. So I think it's the way that some countries, just like Portugal, have been working on, and so this has good results.
Thank you, sir.
Thank you for the question.
Thank you, sir. I would like to keep this question open to the Indian partners as well to get the Indian perspective.
I think what, as per my opinion, and in antimicrobial stewardship team is actually well experienced in in appropriateness, in making appropriate clinical decision making in proper use of antimicrobials, whereas IPC team is almost similarly doing the same thing. They are improving practices in preventing infections. So it is just the matter of preventing infections, and once the infection is there, ensuring the appropriateness of antimicrobials. So actually, both of them are sharing the same goal in order to reduce the AMR. And that is where I think the integration of IPC and AMSP comes. Yeah, that's what my opinion is.
Thank you, Dr. Sangeeta. Thank you. Thank you for answering the question. So the remaining queries will be addressed in the YouTube chat box after we get the reply from the speakers. To wrap up this workshop, let me welcome the most dynamic person, none other than Dr. Sanjeev K. Singh, Chief Medical Superintendent of AIIMS Cochin and Medical Director, AIIMS Faridabad. Over to you, sir.
Right. Thank you so much, Donna, for conducting this session so fantastically well, and it was so very well organized, and very, very proud of this whole project Prevented, where it is a conglomerate of all the European universities and Indian universities, and this international webinar again brings it that synergy which is so important, where the European partner and an Indian partner bring in their expertise and their the work which they have done over the years for patient safety agenda and for implementation of these practices, which is understood to be a done deal, but then definitely it has its own challenges. So thanks, Dr. Kiranjit and Dr. Donna for initiating, doing all the hard work, groundwork, and it came out extremely well. Donna is our associate researcher, and we are very, very thankful for the hard work which she does day in and day out, and bring in all the best practices with the curriculum, and also working with all the schools. Dr. Kiranjit, we started with Dr. Kiranjit, who again basically is the principal coordinator of the whole project Prevented. And she spoke on emergence and spread of antimicrobial resistance. She also did mention about all the various means, the mechanism by which antimicrobial resistance happens, which is extremely important to understand. And it merges with the talk which Mr. Joydeep took, that it needs to be understood by the healthcare provider, it needs to be understood by the community. And it was so simple and it was so explicit, Dr. Kiranjit, that the whole mechanism was very well understood. You also brought in the One Health concept, which is again, whenever we were doing any of the meetings with respect to human health, every time it was brought to our notice that please take care of those who give antibiotics to animal as growth feeds, and also about it is there everywhere, it is there in the water. So you brought in this concept, which is extremely important. Dr. Prakash Narayan, again a champion in the field of AMR, spoke of all the strategies, the global strategies which is present. So there is a global action plan. He spoke about the national action plan. It's not that India has not done anything. There is a lot of movement, but then it is a diverse country, and it has its own challenges. He also mentioned about 3 good states who have had some successes. Kerala being one, Madhya Pradesh being second, and Delhi third. So out of 30 states, if there are 3 states who have performed well and has a plan, then that is a good beginning. So there are some strategies which is in place, and it is definitely working. Dr. Sangeeta, again, very empowered clinical pharmacist who have done remarkably well to implement antibiotic stewardship, and brought in a concept of multidisciplinary team. because it cannot be one man's job. It cannot be an ID physician's job, or it cannot be a nurse's job, or it cannot be an administrator's job. It needs to be a team. And she brought in some of the success stories which are there in the institution, where there is a lot of data, there is a lot of surveillance which is being captured. There is start smart and then focus model, because there is no pre-authorization, but then there are information for restricted antibiotics which is captured, and then it is also shared. But the clinical pharmacists are empowered group, and they run the stewardship program, and it has impacted well with more reduction in morbidity, mortality, and cost of care. Dr. Carlos, thanks for the invitation for congratulations for conducting ICMED at Portugal. What the beach which you had shown in your it looks very exciting, and it looks almost that we need to book our tickets immediately and to be there at ICMED. And I'm sure you would be doing a fantastic job. Dr. Carlos did speak about very important concept of merging the synergy between IPC and AMR, because many a times the clinicians would give a polytherapy or would pump in an antibiotic because they are not very sure about the infection control practices at OR or at critical care units. And he did mention about doing a risk assessments and risk management. He did mention about all practices, the asepsis, isolation, PPE, hand hygiene. And if this is done properly, the burden for antimicrobial, multi-drug, pan-drug, or any of the microorganisms would be less. He did share some of the good check sheets which he's using with CRE and other AMR issues. So that was fantastically delivered. Mr. Joydeep again brought in such a fresh concept of community managing waste, managing infection control, advocacy, reaching out to the community. It is so very important, because they do, since over-the-counter medicines are available, they reach out to the pharmacy, they use the same antibiotic, and an unused antibiotic is all either landfilled or thrown in the water. So very, very well conducted. I'm so thankful for all the faculty today, Dr. Prakash, Dr. Carlos, Dr. Kiranjit, Dr. Sangeeta, and Mr. Joydeep. Thank you so much for accepting our invitation, and thank you so much for delivering such a lucid presentation. It was extremely engaging, and I'm sure those who attended the session would be very, very beneficial, will find it extremely beneficial. Thanks, Donna, for chairing and taking all the pain in organizing this. And I'm sure with this project of Prevented, where 5 European universities and 4 Indian universities are building curriculum, another fantastic, outstanding project where the tackling of AMR is happening at the student level, at the undergraduates and postgraduate level, at human health schools, at animal schools, biotechnology, and also in the community. So Stefano and Dr. Kiranjit leads that project. So thank you so much for joining in today. And I would also like to thank all the delegates who have attended. I know there would be many, many questions. Whatever questions you have poured in, we will try and answer back to you in this forum, and I'm sure it will all be answered. So have a very nice evening, and be safe, and please work towards AMR free world. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you, sir. Extending our gratitude to all the speakers and participants. And participants, please fill the Google form for the e-certificates. Stay safe, stay healthy.